Thanks for coming out, everyone. We're lucky enough to have Dr. Fitzgerald. She's an IR resident at UW, and she's going to be answering questions about residency, her path to radiology and interventional radiology. And then if we have some extra time at the end, we're going to talk about chest radiography and some high-yield imaging finds with that. So welcome to Dr. Fitzgerald, and thanks for coming out and chatting with us.
Thank you so much, Colvin, for inviting me. And it is Kara as a resident. It is requisite. You guys have to just call us by our first names or else we feel too awkward. So Kara, but thank you so much. I'm happy to be here. And not too long ago was in your shoes. So you too can be in my shoes if you want to do it. It's really wonderful. But I will let you get started with some questions and guide the discussion today. And for everybody that's on, I'm so happy that you all chiseled out some time to meet tonight. And Colvin has my email address, and happy to help anybody with any type of questions or hook you up with someone in our program if you have interests regionally or specific questions that might be better for someone else to answer. So don't hesitate to reach out if you have further questions.
If you have any questions for Kara, please just send me a message in the chat if there is a chat. If not, you can send me an email. But otherwise, we have enough on the forums to get started with some questions if that works for you.
Heck yeah.
Great. So I guess the first question that's probably good to ask is, how did you end up finding radiology, and how did you end up finding interventional radiology in medical school?
Great question. I came into medical school kind of with an interest in radiology. I worked in healthcare before medical school, and was kind of interested in, like, I made like a short list, and then like early in medical school kind of started checking out all the different specialties that I was interested in. And I kind of like stuff head to toe in the body. So I was interested in and I was interested in procedures, but maybe not so much like surgery and doing stuff all day long in the OR. I started shadowing early on. I was an Idaho student and started working with Paul Santrico, who's an awesome DR doc in Lewiston, Idaho, who was a phenomenal mentor. And like many things in life, if your mentor is really good, you'll tend to go with the thing that your mentor is doing or suggesting along the way. And I think that helped a ton. So early mentorship. And then I really was able to find that I did like pathology throughout the body and didn't want to like narrow down to one specific area and kind of only do that. And some of the other things I was interested in, like ortho and anesthesia, you kind of find yourself maybe pigeonholed into doing only a certain number of things, AKA like ortho, whatever. You might only be like the hip and knee lady, or for anesthesia, with the general trend of it and stuff, with CRNAs, et cetera, maybe you get like your cardiac, you do an additional year of cardiac anesthesia, and then you're like the cardiac anesthesia lady. So I think those two things, great mentorship. And then I decided I liked stuff head to toe. That was basically radiology itself. And then further on from that, for interventional specifically, being able to do procedures all over the body was like really, really cool. So, and that was one thing that kind of held me back from being super interested in like general surgery. A general surgeon typically isn't actually general. They're just doing more abdominal work. And I also didn't want to like pigeonhole into that. And IR still is not really subspecialized in academic settings. You can find like really niche folks doing like really specific things, but most IR docs know how to use a catheter throughout the entire body. And I really was interested in that. So you can treat stuff head to toe, even for like general IR, more so in like private practice. General IR folks will still take stroke calls, so you can still cover stroke stuff if you want to as well. So it is truly head to toe care, which is phenomenal. Long answer, but that's my answer.
Awesome, thank you. And I think another question someone had is, what is one positive and one negative aspect of IR that you did not learn about until you started residency?
I was thinking about this one. I don't know that any of it, obviously, because I haven't done non-radiology things. So I can't say that this is specific to radiology itself or interventional radiology itself, because folks may have similar feelings like this in other subspecialties. But for diagnostic radiology in particular, one thing that I guess I didn't maybe appreciate to the fullest was how much of a clinician you still really are as a diagnostic radiologist. You're reading through patient notes, trying to figure out what prior treatment somebody has had, looking at prior scans. And often, especially like in the emergency department, you may be making, a diagnosis for somebody for the first time. And you're relaying this information to their clinician. So you're like really pivotal in providing excellent care for patients. And so it really makes you want to do your job well, because you're basically seeing that patient, essentially for like a 5-minute appointment or something like that when you're just reading their CT. So you want to be able to make sure to do a good job. So the reward of it is enough that the drive is there to be able to do really good work, and it's kind of clinical. So and then one of the negatives, I think you don't really appreciate how hard you're studying. I heard this on the interview trail some, and again, it's not like a negative necessarily, but radiology itself, your first year of actual radiology, you're doing so much didactic work that it can be like you're kind of repeating. You feel like you're taking some steps back, because in your TY year, your intern year, whatever you decide to do, you're like, wow, I'm a doctor. You're seeing patients, you're doing stuff, you have some independence. And then your first year back in radiology, or your first year in radiology in general, PGY2 year, you're like super new at everything again. And like having that feeling, it's the first time in like a while that you've had that feeling, probably since like third year of medical school, that you're like, wow, I don't actually know how to do this at all. And you have to study a ton and try to get good. But then like all of your hard work pays off. And so it's also not like too much of a negative thing, but it's kind of it's a different role that you're not used to for the couple years.
Awesome. There's another couple of questions in a similar vein. And they're kind of talking about, that collaborative environment, like in the ER. How much are you speaking with other physicians, and how often are you helping guide the treatment for those physicians?
I love this. So when I was shadowing in medical school, I got to see this community radiologist who was working so closely with so many clinicians. And I loved it because he was actually so social. He was probably one of the most social docs in the hospital, and he saw people would come by the reading room all the time, pop in, ask him a question about like a particular exam, or give him follow-up on something that maybe he found or asked somebody about. And it was not interrupted to the point that it was like annoying, but it was like really fun for him. And he got to like be really involved again with like patient care more than you would probably assume somebody in radiology. You always are like, oh, it's just like a dark room and you're by yourself or whatever. In the academic setting, it's very similar in certain subspecialties. So in the emergency department, it's the Harborview ED reading room is in the emergency department at Harborview. And there's very close contact with all of the ED providers. They're coming in and reviewing stuff. Surgery's coming in and reviewing stuff. The radiologists are going out and looking at the portable, I don't know what their little cart is called, I guess, but the little x-ray techs have like their little x-ray cart machine, their little portable x-ray machine. And you're going out there and like looking at it to see if you can see anything mega bad for like the patient, for the traumas and stuff like that. If they have like a big trauma, part of the protocol is they get a chest x-ray and a pelvic x-ray or radiograph, and the radiologist will go out to the scanner and excuse me, the portable thing, and like look at it on there and tell the team like right away if there's something bad. So you're like, you get to go into the trauma bay and you're seeing the patient care and you're being involved and you're communicating in a way that's like important and stuff. Other specialties, I would say the more pivotal role that radiology plays is with like tumor board. And there's like liver tumor board and melanoma tumor board, and at UW, it's a lot more probably niche ones because we are partnered with SCCA, but radiologists play an incredibly pivotal role in initial cancer staging and then subsequent staging or restaging. And we're respected a lot by like our colleagues in different specialties. But we also respect all of them too, because they have a lot of information about the patients, but it's incredibly collaborative across radiology and in radiology in general. I think something that folks don't appreciate as much is like you're on the phone all the time, relaying messages to providers, asking providers questions about something, in IR all the time, trying to figure out if this is the right procedure for the patient. Gathering more information, is it the right time for the procedure? All of that. So it's you have to be a good communicator if you want to be a good radiologist.
Awesome, thank you.
Yeah.
Did
that kind of answer that question fully? I feel like that question kind of had like two questions in it. Was that?
No, that was perfect.
Okay.
Yeah, that's perfect. I think there was a question, you talked a little bit about, studying a lot during the beginning of your residency. There's one question on what the typical day-to-day of radiology residency is. And someone wants to know how much time off you get and what your average work week is like.
Awesome. I think those are important questions. The classic saying is like the road to happiness or whatever. So it's like radiology, optho, anesthesia, and derm are like typically the specialties that maybe you could have more work-life balance. Obviously, we're using different terminology nowadays, like work-life integration, and saying work-life balance maybe isn't like the best way to describe it because they're more integrated than opposite of each other. But I think folks do need to take that into consideration when they're picking a specialty for their life, especially, and this is going to not be, this is not meant to be offensive to anybody or anything, because I know a lot of wonderful surgeons, male and female surgeons that have families and do a phenomenal job taking care of them, etc. But certain people perhaps would like to have a less work schedule rather than more. Nowadays, you're able to make a lot of modifications, even in general surgery or vascular, with call or working more part-time, et cetera. But radiology traditionally tends to lend itself to a little bit lighter work schedule. One of the reasons is radiology is like shift work. And what I mean by that, it's like the ED, you come in for your shift, it's a 10-hour shift or whatever, and then you go home for the day. It's not office work where you're lingering and writing, catching up on notes from everybody that you were rushed during the day to see. That's one of the nice things is like you get to work, you crush all your studies that you're trying to read, talk to a million people, and then like go home at the end of the day. So the shift work lends itself to be a little bit more reliable overall, I would say. I'm sure there are different areas and situations, breast imaging, preparing for tumor board, et cetera, that you can have some bleed over into your home time or your own time. And in general, this is a little bit different, academic versus private practice versus like teleradiology work or something like that. That would be like private practice, but then like one more step removed and you're just doing it from home. There's so much variability in your scheduling for radiology. IR is on the most time involved. Typically IR residents, I would say, during your 2 busy IR years, and I know there's some questions on IR, and I'll bring this stuff up in just a moment, but so I don't repeat myself too much. In the busy years, it's probably about 80 hours a week. And in your diagnostic radiology years, you're probably working like at work 40 to 50 hours a week. If that, it depends upon your rotation. Some rotations are lighter. Some rotations are, I would say none of them really go more than like 60 hours a week for radiology. But that first year, second year, your board studying year, all of your years have some studying that needs to be built into, and that's time that's work, but it's at your on home schedule or whatever. So it depends upon how much of that you're doing. But radiology in general is less than general surgery, less than internal medicine, call wise, and time spent at the hospital, but you have a lot of that like cognitive prep time that you're still worrying about at home. When you're an attending and you're out in practice, I would say it's more likely to be reliable with time off, etc. In residency, like at UW, we get 1 month a year of vacation. That's 20 days of weekday vacation. We don't work weekends our first year. The second year, we take 6 to 8 weekends. And the same is with like fourth and fifth year, roughly about 8 weekends. As an attending radiologist, I've been asking around and looking at different jobs for a while now, and there's some variation in academic world. It's as little as 5 weeks of vacation with like some continuing education weeks in there too. And in private practice, there's a job I just saw posted in the Seattle area, and it's literally every other week you have off. And you're working like 5 days a week. At UW, we have a position where it's nights, it's night coverage, and you work 1 week of 1 week of nights and you have 2 weeks off. So there's quite a bit of variability, but it tends to be a profession where you can also have a good life.
Awesome, thank you.
Yeah.
So there's some general questions about, exploring the specialty as a third, fourth year medical student, and then that kind of naturally translates into how does the IR residencies work now? How does radiology residency work? So I don't know if you want to bundle that as one question.
Yeah, sure. Third and fourth year stuff, first and second year stuff, I put it back into like that mentoring component, like finding a good mentor. And so getting hooked up with the interest group, I think, is a really great way to do that. I saw Ryan Joyce on here, Dr. Joyce, I believe is one of the diagnostic radiology advisors. And so reaching out to someone like him so you can get hooked in to finding a mentor would be really helpful. And then just paying attention in your interactions in the classroom during like didactic stuff. Look at images from whatever you're studying and see, I don't know, what kind of ways you can peek at stuff and see if that's something that you'd be interested in. It's kind of hard to see a lot in radiology without knowing about it. And it's hard to get excited about some of the studies and stuff without actually knowing some baseline information to be able to like interpret it a little bit. So that's where I feel like having a good mentor is probably the most important aspect. And then for that, I guess we'll do, so the page I have up here is rad.washington.edu, and you can kind of find like the different stuff on this. So the radiology interest group is obviously what you guys are, and this is your page for that. But this is, I was just going to bring this up in case there's anybody here that's not in the DIRIG. This is like a nice area to go and get like some basic information and contact information, more importantly, for folks who can help you out. And then the education, under the education tab, you can find the radiology residency stuff. And since I'll explain DR briefly, but diagnostic radiology, you guys may have heard of this terminology too. It's an advanced program. So residencies in general are either categorical or advanced. All that means is that a categorical program you match once and you're matched through, and an advanced program you have to match to 2 separate things. You need to match for an intern year, which can be a transitional year, general surgery, or internal medicine, transitional year is half and half IM and gen surge or surgery subspecialties. And then so you have your intern year, and then you also have to match into your advanced program, and that's radiology, dermatology, ophthalmology, IR is in that. That's like kind of the background for DR. That it's like that basic. You find your DR program. I should say some DR programs are categorical, so you just have to match once, but most of them are advanced. And then for IR, same thing. Most of them are advanced. There's a few categorical, but IR is a little bit trickier or different in that there are multiple routes to get into IR. On our page, we have under the programs tab, have it kind of listed out like what all the different things you can treat in IR. And these are all things that we do here at UW. Every city is different, or excuse me, every program is different how their clerical or clinical sites that you rotate are set up at. Here, obviously, you guys are all at UW, so we know that we rotate all over the place. But IRs will tend to do that in different cities too. So you'll be like covering different hospitals, etc. That one's not so important. Sorry. So this is the meat of it. For the integrated interventional radiology residency, this is basically what the timeline looks like. So you'll apply to two separate programs. The first program is going to be your intern year. And then your second program is going to be your advanced year. But this is all going to be the same program. In your first 3 years, you get at least 3 blocks of IR. And then in your last 2 years, you'll get predominantly IR. You have to do some breast imaging and some nuclear medicine imaging just to meet like the national requirements or whatever. So you have it within a certain amount of time before you graduate. So you can read that out in practice if you wanted to. So this is a 6-year thing, 2 separate programs to get there. And then you have the independent interventional radiology residency. This is going to be, there's 2 options for this. There's a true independent residency that is 2 full years long, and your total time is going to be 7 years. And then there's this other option that's an ESIR track, which is going to be 6 years overall and 1 year of a dedicated independent IR residency. Basics on this: you do your intern year, you match into a diagnostic radiology residency. The most straightforward one is that you do your DR residency. So you're done with your DR residency. And in your PGY3, PGY4 year, you figure out that you want to do interventional radiology, and you apply to an independent IR residency program. Process is like the same as when you apply the first time. And this is just an additional residency program in addition to like your diagnostic radiology residency. It's not a fellowship anymore. It's just a residency. So you would go somewhere else, like if your program didn't offer it or whatever, you would go somewhere else and do your 2 years of an independent residency there. At the end of this, you would be able to sit for like your boards for diagnostic radiology and interventional radiology. Same with the integrated route. You'll be able to be dual board certified. Basically, everybody can be dual board certified if you sit for your board. So the other route is the one that's a little bit more confusing, but like normal intern year, do that. You apply to a diagnostic radiology residency that has been approved for ESIR. Not all DR residencies are actually approved for ESIR. So it has to be one that is actually approved for ESIR. And then usually how it goes at UW, usually it's about the same time that you'd be thinking about applying to fellowship. So it's like end of PGY3, PGY4 year. You would apply for that internal ESIR spot. And basically what that just indicates is that during your training in your traditional like diagnostic years, they'll make sure that you get 12 months of IR or at least 500 IR cases during that time. And then you still need to apply for an independent IR residency. And this is the same process for like NRMP through the NRMP match program. But instead of 2 years, if you meet this requirement for ESIR and you get like your 500 cases, you can just do 1 year residency. So 1 year of the independent. And then this brings your total to 6 years, this one 7 years. There is like a stickler in there. If you did ESIR somewhere and like didn't get good enough training, they could hold on to you for a little bit longer. So there's a chance that it could be lengthened, but usually this is just 1 year. That is a really long description, but this part is like the most confusing with ESIR. So I just wanted to spend extra time with that. Does that make okay sense, Calvin?
Yep, thank you.
Awesome.
So
Yeah.
there's one more question from the Google form. And
Yeah.
it's, what advice would you give to someone just beginning their radiology residency?
I would say, and this is just beginning their radiology residency. I'm going to assume this is beginning like prelim year, maybe, or maybe I'll say for both prelim year, become a great doctor, like really understand the pathophysiology behind why people are showing up and looking the way that they do. Learn as much as you can from the different folks that you'll be rotating with during your prelim time. And try to, if possible, like peek at their reports and see, what kind of what radiologists are saying while you're taking care of patients on the clinical side. Also, I think one important thing is understand the thought process behind ordering the exam. So when are the clinicians trying to order exams? And it's different. Like med school, you kind of pay attention to that stuff too. But when you're more independent and on your in your prelim year, sometimes you'll have the opportunity to do that more independently. And then when you're in the radiology seat the next year, you'll be like, okay, I remember why, like how I was worried about my patient, and that's why I ordered this chest radiograph. And perhaps it's not 100% indicated or something like that. So it just gives you more perspective later on. And then have fun. I did a TY. It was wonderful. Get out and play and enjoy yourself. Not work hard, play hard necessarily, but like kind of like do your stuff, but then also enjoy some too. If you're doing radiology, you can consider doing your TY or prelim in a completely different city and pick something else if you wanted to like explore somewhere else or whatever. And then some folks also apply into the same city or like the same hospital program so they can have an opportunity to meet more people there, and then you only have to move once, but there are pluses and minuses to both. But I would say follow your heart for that. And this is your one opportunity that you could like check someplace out for you. And I have a lot of friends that did that and got to live in a cool spot that they'll probably never be able to live in again. For radiology folks just starting out their second PGY 2 year, whatever, like their first year actually in radiology, is just be nice to yourself and focus on learning as much as you can, and know that it takes a long time to eat an elephant, and the best way to do it is just one bite a day or whatever. Like take little bits at a time, and know that coaching has been around for a long time, and there's tons of data out there, etc. Like you're going to have ups and downs with your days, and if you can just try to get like 1% better every day, you'll make a substantial improvement over the long run. So know that the little things mean a lot too. And study. Definitely study. Some people will be like, oh, I didn't have to study at all or whatever. Granted, I'm only a PGY 3, so perhaps that's not the best advice, but be prepared to study. I think it only makes it easier. Yeah.
Awesome. Thank you so much. I don't want to eat up any more of your time because I know you only have 30 minutes, but
yes, I'm moonlighting now, so I have to help out my buddy, Dr. Amadian, who is over there reading. So yeah, this is all I have time for today, but awesome. Thank you so much for putting it together, and I'm happy to obviously answer any questions from anybody that was here. Ryan, I should ask you, Dr. Joyce, since you're on, is there anything that I mentioned that you would want to clarify or add to or anything like that?
No, I thought that all sounded good. I don't have anything to add. I'm working myself right now in the ER. But
Awesome.
yeah.
Sweet. Thanks for being on. He's a great resource. So for any of the med studs that haven't had an opportunity to meet with him yet, shoot him an email and use that resource so you can get hooked up with a mentor. That would be really good. Awesome. So that's
Thank you
it.
for coming out. Have a good
Yeah.
evening, everyone.
Thank you so much for organizing. Bye, you guys.
Bye.